Sir, now you are live, you can start.
Welcome Gujarat and welcome Valsad, Surat.
Good evening, Dr. Niranjan.
Yeah, good evening, sir. It's a pleasure to come today personally to Surat and Valsad Society. તમારો ગામ દેશમાં હું આવી ગયો છું અને
Welcome to the Valsad.
yeah,
Welcome from both the society.
ભાઈ યોગિની મેડમ અને મોના શ્રોફ મેડમ મારો ગુજરાતી થોડી તૂટી છે પણ આ બ્રિજિંગ ભારતનો પ્રોગ્રામ છે અને હું થેન્ક્સ કહું છું તમારો પૂરા ઓડિયન્સ માટે આ વેબિનાર છે એન્ડ ફોક્સી વલસાડ અને સુરત સોસાયટી થેન્ક યુ ફોર એક્સેપ્ટિંગ ધીસ એન્ડ I would like to thank our sponsors ભારત સીરમ આ તમારો લેવા માટે આવી ગયો છું આ વન્ડરફુલ ટોપિક છે રિકરન્ટ પ્રેગ્નન્સી લોસ અને મારે સાથે જયેશભાઈ છે જયેશભાઈ is the president of Surat Obstetrics and Gynecological Society and welcome sir. He is working at the Paranu Women Super Speciality Kashi Plaza Surat and has passed MBBS DGO and MD from Srimati NHL Municipal Medical College, PG done under Dr. Behra Mankleshwarya. We miss sir. It was a pleasure to be with him and thank you so much. You have already Foxy recognized ultrasound training center and you have already trained more than 100 gynecologists. I came to know that your topic of recurrent pregnancy loss is very dear to your heart and you have also taken training for ultrasound with Dr. Suresh and fellowship in IVF in BSCC. Very good orator and you have participated in various local, state level and national CMEs. Welcome Jayesh Bhai. Thank you so much. Dr. Percy Kharas. કેમ છો સર?
Kem Cho, how are you?
સર મજામાં મજામાં હું તમારો
Welcome all the
વલસાડનો
participants.
Yeah, I miss your Alfonso
Yeah,
mangoes.
do come down, do come down.
Thank you sir. So Dr. Percy Kharas, you already know, India should know, he is the president of Valsad Obstetric Gynec Society.
Last year president.
Yeah, last year president and he was a founder president. Thank you for correcting that. And he has his own ICSI and IVF center at Valsad, practicing since 1986. He has done MBBS, DGO and MD from Government Medical College in Surat. And he has also Center for Sexual Medicine. He has his own excellent IVF and IUI lab, which is the low-cost IVF, presented many papers and articles in national and international conferences. And he has dedicated his life for women's healthcare and he concentrates on women of the third world in this new millennium. So welcome Percy sir. Thank you so much.
Thank you for the nice introduction. Thank you.
Welcome. And then we have our two young ladies from Valsad, Dr. Yogini G. Rolekar.
Hello,
She is
sir.
President of Valsad Society. She has an own practice, own private maternity and gynecological hospital, that is Yogini Maternity Hospital, doing ultrasound and running IOI center for last 13 years. Her mission of life is for female health awareness and work for women's empowerment activities. We all know she was the secretary last year and presently she's the president. She has been also meeting us in the Foxy PAC and Foxy Adolescent Committee and is a very big motivational speaker, especially for adult females of health awareness and women's empowerment. Thank you so much. You got many awards. I can name them few as the Wonder Foxian Award and you have done a lot of workshops on menstrual hygiene, on adolescent health workshop, and you're also uh, associated with various social organizations. I can see them: Jalasai, Jan Seva Charitable Trust, Mahaya, Vanchi, Mumbai Samaj, and got many awards. So today you will be there with us as a panelist. Thank you, madam, so much.
Thank you so much.
Welcome, Dr. Mona Sudeep Shroff, and you have done emergency obstetric care project from John Hopkins and ICOG Government of India initiative since 2004, master's trainer for Japaico Foxy Government of India program, clinical training skills, UNICEF certified specialist for essential newborn care and resuscitation. He has also been the assistant professor at the Surat Municipal Institute of Medical Education and Research from 2004 to 2008. And presently she is the director for Rachna Women's Hospital, was also the director for the NOVA IVI IVF Fertility Center. So madam, you are the secretary of the Surat Obstetric in 2009 and 10. So you are going to be our panelist for this recurrent pregnancy loss CME. Thank you so much to be here. So now with this introduction, I request Jayesh Patel sir to start his lecture on recurrent pregnancy loss, and I hand over the mic to you. It's all, the floor is yours. Thank you so much.
Thank you, Dr. Niranjan, for a nice introduction of everyone. I will start my screen sharing. Can you see my screen now?
Yes, sir. You can make it full screen. Thank you.
Okay, yeah. So today the topic given to me is recurrent pregnancy loss, and it is a very big topic, but I have been given only 15 minutes. So I will run a little bit fast. So keep with pace with me. First, the definition. There are controversies in definition also, but usually people accept that 3 consecutive losses of clinically recognized pregnancies of less than 20 weeks is considered as recurrent pregnancy loss. Ectopic, molar, or biochemical pregnancies are excluded in the definition. But usually in our practice and world over, the clinical investigation should be started after 2 consecutive spontaneous abortions, especially when fetal heart activity had been identified prior to the pregnancy loss, or when the woman is older than 35, or when the couple had difficulty in conceiving. You can see there are so many studies where there is a different definition is used, and that's why some confusion is there in definition. There is recently a change in the nomenclature. Instead of the word abortion, now the adopted word is miscarriage. The blighted ovum is now known as early fetal demise. So these terminology we should stop using, and these are the things which we should keep in the practice. ASHRAE has given certain nomenclatures. That is, biochemical pregnancy loss is the one where the pregnancy is confirmed by beta HCG levels and it is lost by decreasing beta HCG levels, but not located on ultrasound. Empty sac or anembryonic pregnancy loss is the one which we popularly known as blighted ovum, where there is an intrauterine sac, but there is no fetal pole or yolk sac. Yolk sac miscarriage is one where the yolk sac appears, but no fetal pole. Embryonic miscarriage is the one where the fetal pole is there, but no heart activity. Fetal miscarriage is more than 10 weeks loss. Ectopic pregnancy, all of you know that pregnancy outside the endometrial cavity. Early pregnancy loss is pregnancy loss less than 10 weeks, or late pregnancy loss is more than 10 weeks. And pregnancy of unknown location, that is if you are doing a transvaginal sonography and beta HCG is more than 1500 and still you are not able to locate the pregnancy, or if you are doing transabdominal and beta HCG is more than 6000 unit, then it is a pregnancy of unknown location. So these are the nomenclature given by ASHRAE. The incidence of recurrent pregnancy loss is almost 50% of all conceptions fail. Out of them, most go unrecognized. Among the general population, 13 to 15% of recognized pregnancy also are lost, and 90% of these losses are before 12 weeks. 10 to 20% of the pregnant women have at least one sporadic spontaneous abortion. 2% have two consecutive spontaneous abortion, and 0.4 to 1% have three or more abortions. There is the effect of a previous live birth also. If there is a previous live birth and then there are recurrent abortions, the percentage of recurrence will be comparatively low when there is no previous live birth. Here you can see that the recurrence risk of loss of pregnancy is 40 to 45% if there is no live birth. So the history of previous live birth is a beneficial. So in recurrence, it suggests there is some cause. We have to find out that cause. It is not just a bad luck. So we have to investigate. So what are the causes? Causes of recurrent pregnancy loss, almost 50% are unknown etiology. They may be anatomic cause. Usually they affect in the mid trimester. Genetic causes, they affect very early in pregnancy. Endocrine causes can be affecting at any stage. Immunological causes are very common, and that also usually affects after the heart activity is visible. Psychological, environmental causes and infection causes also play some role. Some molecular mechanism I would like to share that T helper cells are important for the dialogue between the fetus and the endometrium. And these T helper cells, they release two types of cytokines. Th1 cells, they release the pro-inflammatory cytokines, while Th2 cells, they have anti-inflammatory cytokines. So Th2 cells have humoral kind of immunity, and Th1 has cell-mediated immunity. What happens in pregnancy, that is a normally progressing pregnancy, the balance is towards the Th2, where the anti-inflammatory cytokines are more active. So in pregnancy, rheumatoid arthritis gets improved because pro-inflammatory cytokines are less, while anti-inflammatory cytokines increase. So SLE will worsen in the pregnancy. These mechanisms come into play by the action of progesterone, which acts by progesterone-induced blocking factor. And this blocking factor is responsible for balance towards the Th2. But if that blocking factor decreases, like use of mifepristone, or there are anti-PIBF factors, then balance will be towards the Th1 and you will have a miscarriage. Trophoblast invasion is also regulated by the progesterone and this PIBF and towards the Th2. So these endovascular trophoblast and natural killer cells, they cause a syncytial formation and improve the blood flow. But when there is a failure in this mechanism, there will be vasoconstriction and lack of syncytium formation. This leads to preeclampsia or miscarriage. How to improve the blood flow? Nitric oxide is a one thing which helps in vasodilatation, and progesterone brings about increase in the nitric oxide also. Now we will take one by one the causes. One is the genetic causes or chromosomal. Common are the aneuploidies or translocations and inversions, or sometimes parents have a normal karyotype, but there will be de novo copy number variants, and maternal aging increases the risk of copy number variations. Single gene disorders may also play a role. Common are the musculoskeletal disorders like myotonic dystrophy or thanatophoric dysplasia or osteogenesis imperfecta. Immunologic and inflammatory single gene disorders in form of HLA-G and gene, hereditary thrombophilias, and familial recurrent hereditary form mold. So PGD can help settling down these genetic or chromosomal causes. So how to investigate? We have to order for parental karyotype or microarray. Analysis of product of conception also we can do. But many times if some abnormality like aneuploidy is present in product, it may not recur. Genetics of placenta is now catching the importance, and research is going on that. and we can get the results soon. So various tests we can order are karyotype, microarray, next generation sequencing for single gene disorders, or exome sequencing. In the male, aneuploidies may be there, or HLA-G polymorphism, thrombophilia mutation, Y microdeletion, or sperm DNA fragmentation. All my colleagues who have joined here, uh, all are doing IVF practice or IUI practice, so they know what is Y microdeletion and DNA fragmentation. Uh, DNA fragmentation affect badly in ART as well as to the future generation. Uh, there will be low fertilization rate, low blastocyst formation, low pregnancy rates, and disrupted pre-implantation development. So overall, there is a high miscarriage rate in the even in ART also. For future generation, lifespan decreases. There is significant rise in various pathologies, including the malignancy. So overall, high DFI is detrimental. So that is regarding the chromosomal or genetic causes. Now coming to another cause, that is the antiphospholipid syndrome, which is a well-known cause of recurrent pregnancy loss, and it is a treatable cause. There are certain diagnostic criteria which are divided into clinical criteria and lab criteria. Clinically, vascular thrombosis has to be demonstrated either by Doppler or direct examination, except if it is superficial venous thrombosis. And there should be some pregnancy morbidity in the form of one or more unexplained deaths, or one or more preterm delivery before 34 weeks due to PIH or placental insufficiency, or more than 3 unexplained spontaneous miscarriages of less than 10 weeks where maternal anatomical, hormonal abnormalities and chromosomal causes have been excluded. While lab criteria, we can measure anticardiolipin antibody, lupus anticoagulant, and anti-beta-2 glycoprotein at 2 occasions 12 weeks apart. If they come positive, then we can say yes, lab criteria are positive. So for diagnosis of APS, one clinical and one lab criteria should be present. APS can be of 4 variety. Primary APS, that is without underlying any autoimmune condition. Secondary is with underlying condition like SLE. Familial antiphospholipid syndrome, it runs in the family. And the most dreaded is catastrophic APS, which may be life-threatening. Treatment, Percy sir is going to talk about low molecular heparin. Apart from that, aspirin or the traditional heparin also can be used. Some papers have used warfarin, especially after 12 weeks, to avoid the teratogenic effect of warfarin. Steroids usually have no significance, but still some studies have done use of steroids. IV immunoglobulin, plasmapheresis, and fluvastatin are also tried. Screening guidelines by ASHRAE says that for antiphospholipid antibodies, routine screening should be done, especially when there is a 2 pregnancy losses. Autoimmune disorders, one is a thyroid, where we can detect the anti-thyroid antibodies, that is anti-TPO, anti-thyroglobin, or TSH receptor antibodies. And we can treat it by maintaining the TSH level less than 2.5 throughout the pregnancy. SLE is another autoimmune disorder which can lead to abortion. Anti-dsDNA antibodies or complements or anti-Rho anti-La antibodies are the specific for SLE. But we can predict SLE by anemia, leukopenia, thrombocytopenia, raised ESR, ANA titer, or creatine and uric acid testing. So the treatment is hydroxychloroquine, very well known now to the people because of corona. Then low dose aspirin, steroids, immunosuppressants can be used. Hyperhomocystinemia, a few years back it was discussed very much, and now it is also an established cause of recurrent pregnancy loss. More than 100% severe hyperhomocystinemia, MTHFR gene is responsible for it, and folic acid supplementation along with B6 and B12 is the treatment. Hereditary thrombophilia, here is the list: factor V Leiden, prothrombin gene mutation, protein C and S deficiency, antithrombin deficiency. All these are the various hereditary thrombophilia, and we can use low molecular weight heparin in pregnancy for treatment. ASHRAE does not recommend screening for hereditary thrombophilia in pregnancy. So these were the autoimmune factors. Now coming to alloimmune, means the non-self, means fetus is the invader into the maternal body. So cytotoxic antibodies or absence of maternal blocking antibodies or inappropriate sharing of HLA and disturbance in the natural killer cell function. So lymphocyte immunotherapy is tried to treat these blocking antibodies if they are low, and in using these lymphocyte, paternal lymphocytes are preferred over the donor lymphocytes. Endocrine causes I will skip because everybody knows: hyperprolactinemia, thyroid, diabetes, high LH, high androgens, like poor oocyte quality. As we are ART specialists, we come across these with aging, and our females are now prefer to get pregnancy late and late. So there is a poor quality of oocytes and decreased number of oocytes. So ovum donation or embryo donation can be offered, or mitochondrial transfer in some centers over the world, not available in India, but it has been started to rejuvenate the oocyte quality. Anatomical causes, again, Mullerian anomalies, endometriosis, adenomyosis, intrauterine adhesions, or cervical incompetence. They usually come into play in the mid trimester. Infections, especially in our country, genital tuberculosis and bacterial vaginosis are very common. Other causes are hydrops, immune or non-immune, late pregnancy loss or recurrent molar pregnancy, and recurrent implantation failure is also now considered as recurrent pregnancy loss. So some empirical management options I would like to discuss, that is progesterone and dydrogesterone. There are two types of progesterone receptors, A and B. The B receptors, they are stimulatory activities for progesterone, while A strongly inhibits the action of B receptors. So the balance between two will manage the pregnancy. Progesterone acts by progesterone inducing blocking factor that already we have discussed, Th1 and Th2 types of cells. They decreases the natural killer cell activity and improves the blocking antibodies and other functions. So overall progesterone helps in maintenance of the pregnancy. It improves the endometrial maturation, endometrial stabilization, and the embryo implantation and inflammatory mediated processes. Uh, there are so many progesterones available, but commonly used are the natural micronized progesterone and the dydrogesterone. They are commonly used in recurrent pregnancy loss. Role of GCSF is not well established for recurrent pregnancy loss, but when there is a thin endometrium and there is a recurrent implantation failure, GCSF helps, that everybody knows as IVF specialist. IVF can help in the form of IMSI, where we can select a good quality sperm. So it will reduce the chances of pregnancy loss. PGD also can help us to select a chromosomally normal embryo for transfer. Ovum donation, embryo donation, or surrogacy are also part of IVF, and which can be used when there is a appropriate cause. Oxidative stress can affect the sperms, oocytes, embryo, everywhere it will affect. And to reduce that oxidative stress, we should also supplement antioxidants and micronutrients along with the other definitive treatment. So it will also prevent the recurrent pregnancy loss. Tender loving care to the mother along with all kind of treatment, that is very much important, and it should be used as adjuvant to other therapies. So thank you very much for patient hearing. Dr. Niranjan, now it is back to you.
Thank you so much, sir, for a wonderful presentation you have done. And we will come back to you very soon. Now we go to Dr. Percy Kharas, who will be talking on low molecular weight, heparin, and recurrent pregnancy loss. Thank you so much.
Thank you, Dr. Niranjan, for
Yes,
a
sir.
very nice introduction. And we will proceed to low molecular weight heparin in recurrent pregnancy loss. Now, this is a very specific topic, but a very controversial topic, and I'll try to make it as simple as possible. Next slide, please.
Yes, sir.
They'll be working, yes, the slides from there. Sorry for that. Yeah, can you hear me?
Yes, sir. Yes, sir. Thank you. Please
Hello?
go ahead. Yes, sir. We can hear
Hello?
you. Please carry on. You can carry on.
Hello?
Please. We can hear you. We can hear you, sir. Please go ahead. Thank you so much.
Hello, can you hear me?
Yes, sir. We can hear you.
Hello?
I can hear.
Can you
Please go
hear
ahead.
me?
Yes, yes.
Sir, we can hear you. Please
Hello?
start.
Yes, you are audible.
Hello, can you hear me?
Yes, sir. We can hear you.
Hello? Hello?
Sir, we can hear you. Go ahead. Please go ahead. Thank you.
Hello?
Sir,
I
please
think,
start. Please start your presentation. We can surely hear
Hello?
you.
Hello?
I
his
think,
microphone may not be working.
I
Or
think his audio is
Hello?
audible to us, but we will go ahead with the program.
Hello?
We will surely join him.
Hello?
We can hear him, sir. We can hear him. Thank you so much.
Hello?
it's his earbuds may not be properly fitted.
Hello?
Yeah, probably. Can someone call him? That would be so nice.
Hello?
These are all the small glitches which we come across in our TOG webinar and any other webinar. But
Hello, can you hear me now?
Yes, we
Yes,
can
sir.
hear
Can
you.
you hear me?
Yes, sir.
Yes, we can hear you.
Yeah, sorry, but in between some technical problem happened. Sorry.
Please go ahead.
Yeah, just tell them to put the slide, please.
Yeah, it is already there. Please go ahead. Thank you.
Yeah, the first slide, please. Yeah, the first
Anuja.
slide, please. Yes. So now, before discussing low molecular weight heparin, what is important now is to have some idea about unfractionated heparin. Then only low molecular weight heparin can be understood properly. Can you hear me all of you?
Yes, sir.
Okay. So actions of heparin, inactive by itself as an anticoagulant, requires the presence of plasma cofactor antithrombin 3, AT3. Now this is very important to remember. Without AT3, heparin is not going to act. Heparin potentiates the action of AT3. Heparin AT3 complex neutralizes the action of all these factors and binds to lysine sites on AT3, leads to conformational chain at the arginine reactive center. Next slide, please. AT heparin complex. This just shows how the heparin AT3 complex inactivates the coagulation enzyme factor, all these numerous factors, and the thrombin-induced activation of factors 5A and 8A is inhibited by the heparin AT3 complex. Next slide, please. Heparin binds to saturate sites on the endothelial cells. It is internalized and depolymerized. It displaces platelet factor 4 from the endothelial cells, a protein that neutralizes heparin. Next slide, please. Heparin anticoagulant action is modified by fibrin. Clot-bound fibrin binds thrombin and protects it from inactivation by heparin AT3. Platelets binds factor 10A and protect it from heparin AT3 complex inhibition and by secreting platelet factor 4. Not the case with hirudin, AT3 independent. Subendothelial thrombin is protected from heparin AT3 as well. Next slide, please. Now, what are the adverse effects? See, these are some reasons why unfractionated heparin is nowadays not being much used and not advised, because major bleeding, thrombocytopenia with thrombosis, osteoporosis, even rare cases of anaphylaxis, skin necrosis, local urticaria, all these problems are many a time seen. Next slide, please. Induced thrombocytopenia, two forms: mild reduction in platelet count, and platelet count usually remains about 1 lakh, then the bleeding risk is minimal. Next slide, please. Heparin-induced thrombocytopenia and thrombosis, severe reduction in platelet count 7 to 14 days after initiation of therapy with full dose or low dose heparin. This is again one of the problems with unfractionated heparin. May be associated with thrombotic complications, including arterial thrombosis with platelet fibrin clots that may cause MI or stroke. Presence of antiplatelet IgG in patients with severe form. This is something which is being studied now, and very soon we'll get reports of that. May be less common with heparin from POC. Laboratory monitoring, APTT, TCT therapy, routinely monitoring by means of APTT. Clotting time of 1.5 to 2 times the normal means APTT value is therapeutic. Initially, the APTT should be measured and the infusion rate adjusted every 4 hours. See, why I have put this slide is heparin laboratory monitoring and heparin monitoring in the ward is a little clumsy, little complicated, not as swift as low molecular weight monitoring. Some patients may not show prolongation of APTT unless very high dose of heparin are used. Presence of an increased concentration of factor VIII will give rise to a very short control of APTT. Accelerated clearance of heparin may exist. Inherited AT3 deficiency, acquired AT3 deficiency. Anticoagulant effect of heparin disappears within hours after discontinuation of the drug. Mild bleeding due to heparin can be controlled without administration of an antagonist. Antagonists are used if bleeding is life-threatening. Next slide, please. Next slide, please. Next slide. No, the previous slide, I think. The previous slide. Yeah, after that. The next slide, next slide. Next slide. Yes. Go on clicking. Next slide. Yes. So the degree of over anticoagulation, presence or absence of bleeding, a specific immediate heparin antagonist, that is protamine sulfate, has to be used. Next slide. Use is 25 to 50 milligram intravenously. Side effects largely allergic in nature. Pregnancy, heparin is the anticoagulant of choice, was before, but we will see further why, because of osteoporosis and number of problems, we have now switched over to low molecular weight heparin. Next slide, please. So enoxaparin and dalteparin are the common low molecular weight heparins which are being used nowadays, contain a low proportion of critical pentasaccharide sequence that the parent compound. They increase the action of AT3 on factor 10A, but not its action on thrombin. This is very important compared to usual unfractionated heparin which was used previously. Next slide, please. The low molecular weight heparins are not inactivated by platelet factor 4. Therefore, activity extends to factor 10A bound to platelet membranes. In clinical doses, no effect on platelet reactivity, PT or APTT. Currently approved for prevention of deep vein thrombosis after hip or knee surgery, for abdominal surgery, and a lot of obstetric causes, and also in IVF. Do not require routine monitoring of INR, PT or APTT. This is very important compared to unfractionated heparin. One fixed dose administered subcutaneously, 30 milligram every 12 hours, but in some cases 40 milligram may also have to be used. Must not be administered intravenous or never IV administered. It is always subcutaneous. Used with caution in patients with history of heparin-induced thrombocytopenia. Reversal by protamine 1 milligram for each milligram of low molecular weight heparin. Next, please. Now, this is a very interesting chart on unfractionated heparin, low molecular heparin, and the new fondaparinux. Now, we do not have time. See, I have to finish my talk in about 15-20 minutes. We do not have time to discuss each one of these. Otherwise, it would be very interesting to the listeners. But if you see carefully the slide, routine monitoring, dosing frequency, clearance, pregnancy, breastfeeding, ability to cause HIT. HIT means heparin-induced thrombocytopenia. Use in heparin-induced thrombocytopenia treatment. Use in patients with a history of heparin-induced thrombocytopenia. If you study this carefully, you will see that the best is low molecular weight heparin, much, much superior compared to the previous unfractionated heparin. Yes, fondaparinux is as good as low molecular weight heparin, but the main problem is it's not available everywhere. And secondly, not many papers have come of its use in clinical practice. And therefore, for a patient who's a serious problem and we require to use, people usually fall for low molecular weight heparin rather than the new fondaparinux till it proves itself. Next slide, please. A very good comparison of enoxaparin with dalteparin and tinzaparin. Now, Lovenox, which we all know, is a very good product. Fragmin is also a good product, but not available everywhere. And tinzaparin is a new product, that is Inohap. Again, the same problem, not much in use, not very many papers. So it's very difficult to speak much about tinzaparin. But if you see the concentration IU per ml of all the three, the anti-XA activity. Now, what do you mean by anti-XA activity? It is a lab parameter which measures unfractionated heparin and low molecular weight heparin. If you see the dosing based on selected indication in patients with normal renal function, prophylaxis of deep vein thrombosis, treatment of active symptomatic deep vein thrombosis, treatment of symptomatic VTE in patients with cancer, and all these factors. Also, our management in pregnancy, management in IVF patients, you will observe that Lovenox is far more superior to Fragmin and Inohap both. And that's why Lovenox has been very commonly used by all of us. I'm not going into the detailed doses of each factor to be used in each factor, but efficiency of Lovenox and superiority of Lovenox is definitely proved compared to the other low molecular weight heparins. Next slide, please. Monitoring UFH. Now, I've just put this slide and not going into much detail of it, just to show that monitoring unfractionated heparin, which we used to use previously, I've also used before many years, it is very difficult and very clumsy compared to the simplified monitoring of low molecular weight heparin. Next slide, please. Now, this is a very important and a very interesting slide of low molecular weight heparin. There is a protocol for use of enoxaparin. If a patient is unable to tolerate unfractionated heparin, as I already told you, a lot of problems with it due to injection site reaction, example, hives, wells, itching, osteopenia, osteoporosis, or heparin-induced thrombocytopenia, informed consent is obtained and patient is started on enoxaparin. Enoxaparin is a very good compound which gives very good results. Patient with only one isolated low risk factor may be eligible to have anticoagulant therapy discontinued after the first trimester. Patients are referred for diagnosis management of thrombophilia by the obstetrician or primary care provider later on. Risk factors for venous thromboembolism or pregnancy loss. Why does pregnancy loss occur? Why does venous thromboembolism occur in these women? Positive ANA, anti-cardiolipin antibodies, these are all the risk factors. IUGR, history of IUGR, prothrombin mutation, lupus anticoagulant, antiphospholipid antibody syndrome, APLA, factor V Leiden, infertility unexplained, history of CVA or deep vein thrombosis or VTE, history of stillbirth, elevated platelet aggregation score, elevated lipoprotein, homocysteine, history of miscarriage, history of preeclampsia, antithrombin 3 deficiency. See all these factors, and last but not the least, the health syndrome, hemolysis, elevated liver enzymes, and low platelet count, which three make the health syndrome. This is very, very important to know whenever you are trying to study a patient with venous thromboembolism in pregnancy or repeated pregnancy loss. Dosing, starting dose is 30 milligrams subcutaneous every 12 hourly, but as I said, 35 to 40 milligram 12 hourly can be given for greater gestational age. And goal anti-XA level, target range for prophylaxis is 0.2 to 0.4 IU per ml. Anti-XA level obtained weekly at 5 to 6 hours post-dose. This is very important. Don't just send for anti-XA level at any time. Send it at 5 to 6 hours post-dose. Monitoring interval may be extended for patients who have been stable on the same dose for several visits. Next slide, please. Next slide, please. Protocol for use of enoxaparin. Prophylactic dose adjustment. Anti-XA level dose adjustment. Less than 0.1 increase by 3 to 5 milligram per dose. 0.2 to 0.4 continue same dose. Greater than 0.5 or less than 1 decrease by 3 to 5 milligram per dose. Delivery. Last dose of low molecular weight heparin 36 hours prior to planned delivery. For high-risk patients, example acute VTE, prostatic heart valve, last dose recommended 24 hours prior. Can you hear me properly?
Yes.
Do you all hear me?
Yes, sir.
Yes, sir,
Okay.
we can hear you, sir.
Okay. For patients with lower risk, therapy may be discontinued 72 hours prior. For spontaneous delivery, delay epidural analgesia by at least 10 to 12 hours after the last low molecular weight heparin dose. Postpartum therapy. You must never forget that there is something like postpartum therapy also after delivery. Patients who require continued anticoagulation should resume low molecular weight heparin therapy 12 to 24 hours postpartum. Begin warfarin 7 days postpartum to goal INR range of 2 to 3. Continued for at least 6 weeks postpartum or as indicated. Next slide. Treatment guidelines for use of anticoagulants in RPL. Recommendations for women who fulfill the laboratory criteria of antiphospholipid syndrome and a history of 3 or more pregnancy losses, we suggest administration with low dose aspirin, 75 to 100 milligram per day. Nowadays, they say that 75 is not enough. 100 milligram per day is the ideal dose, starting before conception, and a prophylactic dose of heparin, starting at date of a positive pregnancy test over no treatment. The guidelines suggest offering anticoagulant treatment for women with 2 pregnancy losses and antiphospholipid syndrome only in the context of clinical research. But nowadays, after this clinical research papers have come out, they have been suggesting, the guidelines are suggesting anticoagulant treatment with antiphospholipid syndrome right from the starting of pregnancy. Next slide, please. RCOG guidelines. Pregnant women with antiphospholipid syndrome should be considered for treatment with low dose aspirin plus heparin to prevent further miscarriages. Next slide. Now, this is a very detailed slide about how to approach recurrent pregnancy loss 2 or more unexplained, recurrent pregnancy loss 3 or more, unexplained and with antiphospholipid syndrome, recurrent pregnancy losses, 2 or more, and inherited thrombophilias, history of severe preeclampsia, unexplained. See, if we start discussing this slide, it's a very interesting slide. Each point in each type of problem has been very nicely put and discussed, but because of lack of time, I can only say with a fair amount of clarity that what this slide wants us to say is, in most of this condition, aspirin with low molecular weight heparin or low molecular weight heparin alone has worked wonders, saved the mothers and the babies, and done a very good work in these kind of patients. Next slide, please. Evidences. Thromboprophylaxis with low molecular weight heparin resulted in improved live birth rate in patients with 2 or more consecutive unexplained recurrent pregnancy loss. Nevertheless, these findings need to be still confirmed in larger randomized trials. Next slide, please. Cochrane reviews. No, one slide before that, please. Yes, Cochrane reviews. Now, from the Cochrane library, Cochrane reviews, which are the most authentic, on which the world of reproductive science and obstetric gynecology also moves. Enoxaparin prophylaxis resulted in an increased live birth rate as compared to low-dose aspirin. So now, out of number of studies which the Cochrane library has collected and on which we depend, and which are usually very dependable, it has been now proved that enoxaparin or low molecular weight heparin is the results in increased live birth rate are definitely far superior than low dose aspirin. Next slide, please. See, this is a comparison between enoxaparin and low dose aspirin, and the comparison with the number of patients who have had very good results very clearly show that enoxaparin is far superior to low dose aspirin. Next slide, please. Protocol for use of enoxaparin during pregnancy results from 85 pregnancies, including 13 multiple gestation pregnancies. Enoxaparin was safe and effective for preventing thromboembolism and adverse obstetric complications in patients, including 12 out of 13 multiple gestation pregnancies. Now, this is a very satisfying paper, a very satisfying statement which I've brought here. The main reason being, most of the time in multiple gestation pregnancies with this kind of conditions, it's a very big headache than a pregnancy with a single baby in utero. And enoxaparin has given very good results in this kind of patients with multiple gestation pregnancies also. This is very satisfying to us. Next slide, please. Thank you.
Thank you so much. Thank you so much, Dr. Parsi. It was a wonderful presentation.
Yes, thank you, sir. Thank you.
Thank you, all of you. So wonderful presentation you have done today, and I'm very happy that both the presentations were on time. Thank you, both of you from Surat and Valsad Society. We have got many questions which are lined up here. So can we begin with the question answer sessions with your permission, sir?
Yes, sir. Go ahead.
Yes,
Yeah,
yes.
thank you.
Yes,
Thank you
yes.
so much. So welcome Mona and Jayesh and Percy. We will go ahead with the presentation which you have already done. So the first question is to Dr. Jayesh, sir. What are the various treatment options and pregnancy outcome in women with idiopathic recurrent miscarriages? Dr. Jayesh.
Oh, thank you, Dr. Niranjan.
Yes, sir.
Various treatment strategies have been tested. I would suggest use of aspirin and low molecular weight heparin in idiopathic recurrent miscarriage also. Over and above, prednisolone, folic acid, and progesterone are also recommended. So in our Deshi terms, we can say it as a mixed masala. Aspirin is cost effective and have minimum side effects. But as Percy sir has just now said that heparin is much more effective compared to aspirin. But many people, they recommend that both should be given. Prednisolone has anti-inflammatory effect, and that's why it can be used. Progesterone is also very well established for recurrent pregnancy loss, and its role cannot be denied. Folic acid supplementation to cover the hyperhomocystinemia and for prevention of the anomalies also, not only for neural tube defects, but many other genetic abnormalities also can be prevented with the help of folic acid. So at least these much drugs I would like to give to my patient of idiopathic recurrent miscarriage. Thank you.
Thank you. Dr. Percy, how
Yes.
effective is the low molecular weight heparin in improving the live birth rate in patients with 2 or more consecutive unexplained recurrent pregnancy loss? Can you throw some light on that?
Thank you very much, Dr. Niranjan. Can you hear me? Can you hear me clearly?
Yeah. Sir, your
Okay.
voice is the loudest of all.
Thank you so much. Thank you. Clinical data has indicated the usefulness of low molecular weight heparin in women with unexplained recurrent miscarriage. There is no doubt about that, because a lot of clinical data has been collected till date. A prospective randomized study about administration of LMWH and aspirin to unexplained recurrent miscarriage case conducted by number of workers on a number of women were randomized at 40 milligram enoxaparin group and 100 milligram aspirin group. And as soon as fetal cardiac activity was seen, prophylaxis was started and live birth rate was 81.5% in enoxaparin group and 84% in aspirin group. So nearly the same, touching same in both the groups. Workers have even said that a live birth rate of 81% using enoxaparin 20 milligram a day in women with greater than 3 fetal losses suffering from URM when compared with control group with a live birth rate of 48%. So this very clearly shows the advantage of low molecular weight heparin. A modest improvement in outcomes as reducing early and late spontaneous abortions for women with recurrent pregnancy loss with unexplained etiology treated with low molecular weight heparin over no treatment when given in first trimester and continued throughout pregnancy. So this also shows the advantage of low molecular weight heparin. The consensus is combination of low molecular weight and heparin and aspirin is superior to aspirin alone in achieving more live births. As the same thing what I mentioned in my lecture also. Therefore, it is recommended treatment for recurrent miscarriages with antiphospholipid syndrome also.
Absolutely. There are various studies, and I would like to tell here, Dolitsky et al. Also did this study, and Fauzi did the study in 2008. And obviously, we had Ahmed Badawi, who was here in Mumbai about 1.5 years back. And his study of low molecular weight heparin in patients with recurrent early miscarriages of unknown etiology was permitted and published in Journal of Obstetrics and Gynecology as early as 2008. So there is obviously a big role and effectiveness of low molecular weight, and it surely improves the live birth rate in patients who have got recurrent pregnancy loss. Wonderfully explained by Dr. Percy. We are very grateful to you. Thank you so much, sir.
Thank you, sir. Thank you. Thank you for your nice comments. Thank you, sir.
Thank you. Thank you so much. And now we move on to thromboprophylaxis. And we have Dr. Yogini here. Can you please throw some insight on this, that whether it should be given to women with previous history of recurrent miscarriages of unknown etiology? Should thromboprophylaxis be done in such cases? Dr. Yogini. Please unmute your mic. Thank you so much. I think Dr. Yogini is not there. So probably we have lost the connection with her. We will move on to Dr. Mona Shroff. Dr. Mona Shroff, would you be kind enough to be there present?
Yes, yes, I'm good.
Yeah, thank you. Welcome, Dr. Mona Shroff. We have already introduced you. So, my question is, what treatment do you suggest for APS positive women? When to commence the treatment, and what are the dose you prescribe?
Okay, so for antiphospholipid syndrome, to commence the treatment, the woman has to fulfill the criteria, whether the clinical criteria or the lab criteria, either of it, and only then we should start the actual treatment for APS. And the lab criteria should be at least 6 weeks apart if twice it is positive. Then once the diagnosis is confirmed, there are again two schools of thought as already discussed by Dr. Jayesh Bhai also, that earlier we used to start after 7 weeks, that is after the onset of cardiac activity. But now the recent data says that the heparin can be started earlier. So even through the luteal phase, if it is an IVF cycle or if it is a non-IVF natural pregnancy, in that case, then we start as soon as the pregnancy test is positive. The
Okay.
dose would be depending on like the type of heparin what we are using. A combination is already nicely narrated by Dr. Percy, that we use a combination of aspirin, low dose aspirin and heparin. And most of us use enoxaparin as the most preferred form of, because of the less side effects, no monitoring needed. So if we are using for prophylaxis, it is usually lower, that is 0.4 to 0.6 milligrams per kg body weight per day. And if it is for therapeutic purpose, it is higher, like 0.8 to 1 milligram per kg per day. So that ranges from 20 IU per day. If it is a very thin patient, 20 to 30 IU per day for prophylaxis, to up to 60 to, even in some cases, obese patients, up to 120 milligrams per day in divided doses.
Okay. Okay. Thank you. Thank you so much, Dr. Mona. Thank you so much. Dr. Jayesh, can we go ahead with the next question to you?
Yes, I'm ready.
Yeah. Yeah. Can you clarify on the low molecular weight heparin and its use in women with inherited thrombophilia?
In case of inherited thrombophilia, ACCP guideline as well as RCOG guidelines are there, but they differ with each other. The ACCP guidelines does not recommend the prophylactic use of heparin
Okay.
to this inherited thrombophilia, but RCOG guidelines, they recommend the consideration of low molecular weight heparin prophylaxis in asymptomatic patients, especially factor V laden and prothrombin G2021A gene mutation, and it is also recommended in antithrombin deficiency, protein C and protein S deficiency also. So if you go with RCOG guideline, then you should use low molecular weight heparin prophylaxis. Clinicians like us, they are obliged actively to manage such risk factors. And whenever there is a likelihood of preeclampsia or IUGR, in those cases also, we should use the prophylaxis of low molecular weight heparin, even in inherited thrombophilia. Thank you.
Yeah, there are data which also shows that there is a potential benefit from low molecular weight heparin treatment, especially during the implantation and placental development, and it's quite beneficial in assisted conception treatment. So this is a study in 2016 where I would like to add Dr. Jayesh sir, with your permission, by Dr. Laura Ormesher, and they have done this in their university, and this was done in London, where they managed inherited thrombophilia in pregnancy with low molecular weight heparin treatment. And it's very important to consider the timing of treatment in relation to implantation in their study. So thank you, Dr. Jayesh. And now we move to Dr. Percy, sir. I want to know from you, Dr. Percy, can you hear me?
Yes, sir.
Thank you so much.
Yes,
Yeah,
sir. Yes,
is
sir.
is natural micronized progesterone beneficial in women, especially when they are bleeding or having history of more than 3 miscarriages? Because now we have got synthetic progesterone, micronized progesterone, and there are various other types of progesterone. So what would you recommend,
Very
especially in such women?
See, sir, natural micronized progesterone is the gold standard. I would say it's the
Wow.
gold standard. It has stood the test of time. Natural
Absolutely, I agree.
Yeah, it has been shown to modulate the contractility of the fallopian tubes, facilitate the myometrium for gamete embryo transportation throughout the uterotubal cavities and for successful implantation. Thus, it decreases the rate of abortion. There is no doubt about it, and it has been seen and proved everywhere. The hormone is also necessary for the successful implantation and maintenance of pregnancy. It has been postulated that inadequate secretion of progesterone during the luteal phase of the menstrual cycle and in the early weeks of pregnancy is one of the causative factors and one of the main mischievous factors for miscarriage. Hence, progesterone has been used during the first trimester of pregnancy to prevent spontaneous miscarriage. In women presenting with a clinical diagnosis of threatened miscarriage, use of progesterone definitely reduces the rate of spontaneous miscarriage. So, as I said in the beginning, it is gold standard. Lot of papers are there. Lot of work has been done. We have seen in our own experience also. And it is a very good product. There's no doubt about it.
Yes, absolutely. I would like to reiterate here that a study which has been done by Sakone G. Sean, and they have done a systematic review and meta-analysis of this randomized control trial, which got published in Fertile Sterile 2017. And they found it to be quite helpful, especially in those women who have got a clinical diagnosis of threatened miscarriage, and the use of progesterone has reduced the rate of spontaneous miscarriage in the subsequent pregnancy. And that has also been evaluated and seen and confirmed with the Cochrane database systematic review, which was done in 2013 by Haas, DM et al. So, Dr. Percy, thank you so much for this wonderful explanation which you have given. And I could also add some few points in your answer. Thank you. So,
Thank you,
Dr.
sir.
Mona,
Thank you.
can we move to the next question? Dr. Mona, are you there? Dr. Mona, will you please unmute your mic?
Yes, I'm here.
Yeah. So I would like to ask you, now we have talked about the recurrent pregnancy loss and 3 miscarriages. So what do you feel is the effectiveness of using natural micronized progesterone in women undergoing ART? Can you throw some light on that?
Yes, so it is one of the cornerstones of treatment, luteal support in ART, because when we are stimulating in IVF with gonadotrophins and antagonists, the progesterone levels are affected, and they are affected to a very large extent. So we need to supplement the luteal support with the progesterone. Now, usually, conventionally, initially it started with injectable, then vaginal, then gel came, oral supplementation came. So there are different routes. The dosage is yet to be standardized, because people use 300 milligram twice a day along with oral. Some use 400 milligram twice a day. So different dosage are there. On an average, we use the standard dose of 800 milligrams natural progesterone per day. And it
But
is
madam,
one of, yes,
in the Indian scenario, I would like to interrupt. I'm very sorry about that.
yes,
In
yes.
the Indian scenario, with ART being there, the women, do they really like the tablets in the vaginal route? So is there any reluctance which you find in your IVF practice, or
Not,
oral would be recommended? I want you to throw some light on this.
yeah, so practically, we have not seen many patients resisting, because the other options are to use only oral, which is again, it's a new concept after the Lotus trial, that to shift over to only oral progesterone is, because as Dr. Percy rightly said, the vaginal progesterone or natural micronized is time tested. It clears the first pass metabolism as well. but probably slowly the changes might occur to oral. Obviously, for any patient, if given a choice, oral would be more I mean, better to take oral, because some even have a lack of privacy to insert the tablets and all. So we get patients who even say that we or if they are working, so then they get the timing to adjust the vaginal progesterone and all becomes difficult. And then there is but the Lotus trial has definitely proven that oral is equally effective, as effective as vaginal progesterone in but that is a comparison between dydrogesterone and natural progesterone.
Oh, so nice. You have explained, Dr. Mona. And I think Dr. Yogini has joined with us. If she is already there, we can ask her a few questions. Is she there? Otherwise, we will move on to the next speaker, and that would be better.
She's there.
So thank you. She's there?
Yeah, she's there.
She has to
So can I
unmute
hear her
herself.
voice?
Yes, I'm here.
Oh,
In
Dr.
between, all the system got, I don't know, something was wrong.
Yeah. Doctor, are you there? Can you see the presentation and the question answers which are
Yes.
there in front of you? Then we will go ahead and ask to you.
Yes, please.
Or should we come back later? You decide and tell us.
You can.
Okay, thank you. So nice of you. So we are continuing right now on micronized progesterone and the route of administration, and the vaginal administration is there, and oral administration is there. So can you throw some light on oral administration as compared to the vaginal progesterone that we have to do as a supplementation in LPS?
See this, like during the luteal phase of the treatment, oral administration resulted in a significantly higher progesterone levels and a significantly lower concentration of progesterone dependent insulin-like growth factor binding protein 1. Now, the investigators suggested that the vaginal progesterone stimulation of insulin-like growth factor binding protein 1 may result in a lower pregnancy rate by deterring embryo implantation.
So we have got two schools of thought. One is oral,
Yes.
and one is vaginal. So I think as Dr. Mona reiterated and you have also reiterated, oral administration seems to be a better option for luteal phase support, and especially
Yes.
it will be helping to increase the pregnancy rate by deterring the embryo implantation. It will be helpful for the embryo implantation. So thank you, doctor. So we come back to now Dr. Jayesh. Dr. Jayesh, can you hear me?
Yes, I can.
Yeah, thank you. Sir, there are various tests for diagnosis, and you are an expert in your field of recurrent pregnancy loss when I just discussed with you 3 days back. So can you just highlight some of the tests which can be done for this diagnosis, and how would you approach a case of RPL? Obviously, you have covered that in your talk also, but there are many viewers who have joined us now, and they would like to hear from you again. Thank you so much.
Okay, we will go cause by cause. For uterine factors, 3D ultrasound or sonohysterography or HSC or hysteroscopy or MRI can be used for diagnosis. Hysteroscopy is useful for treatment also. Septal resection correction, correction of the shape of the cavity. Asherman also can be corrected with hysteroscopy. Myomectomy laparoscopically can be done, polyp removal, adhesiolysis, all these can be possible with hysteroscopy. Then antiphospholipid syndrome, I have already discussed the diagnosis that we have to go with clinical and lab criteria. Among the lab criteria, anticardiolipin antibody, anti-beta-2 glycoprotein, and lupus anticoagulant has to be there at least at 2 occasions 12 weeks apart. And if it is present, then we can say it is a antiphospholipid syndrome, and already treatment is discussed, that is heparin and aspirin. Endocrine abnormality like thyroid hypothyroidism, if it is there, we can treat with L-Troxin. Prolactin is hyperprolactinemia, can be corrected with bromocriptine or cabergoline. If it is diabetes, we have to correct with either weight loss and dietary modification or metformin, or if necessary insulin also. Genetic causes, we can order for karyotype of product of conception or parental karyotype, or for single gene disorders we can go for exome sequencing or next generation sequencing. For treatment part of the genetics, usually there is no treatment if something is abnormal, but we can have multiple embryos and we can do PGD, and out of them, out of many embryos, we can select the normal embryos for embryo transfer. Among the environmental factors, we have to screen for smoking, drugs use, alcohol, caffeine intake. So all these factors we have to remove if there is a presence of these factors. Psychological support, I have told that tender loving care is necessary, and if necessary, psychiatric reference also we can do. In case of unexplained infertility, we have to test all these tests to rule out all the factors. But if there is everything comes normal, we can treat these patients with progesterone supplementation, immunomodulating agents, and PGS also if necessary. And empirical treatment with heparin and aspirin also can be tried. In case of luteal phase defect, we have to treat it with the progesterone. That is a proven therapy. If there is a chronic endometritis as a cause, endometrial biopsy will prove that it is endometritis, and antibiotics will help. Other infections, if they are present, then also we can give the antibiotics after doing the cultures. In case of male factor, especially the DNA fragmentation is there, we can do the DFI. And if it is high, then lifestyle modification, loose undergarments, multivitamins, antioxidants, all can be tried. And if there is still there is high DFI, we can offer the donor sperms also. So we have to try to find out the causative factor with various tests. And if we can find out the cause, we have to treat that cause. And if there is unexplained, we have to give the empirical therapy in the form of either progesterone, heparin, aspirin, or prednisolone. Thank you.
Oh, wonderfully explained, sir. And I have to show you something. Just from my kitchen, we have made dokla.
Oh,
I'm offering you dokla.
actually, it's a specialty of Surat, Khaman and Dokla.
Yes, sir. Yes, sir. I hope you can see.
Yes.
Yes.
So, viewers, we are in Surat right now. I'm in Surat, and it's dinner time. We will be having dokla. Come on. Thank you.
Company of Alfonso will also there with along with Dokla.
Yes, sir. Yes, sir. Percy, sir.
Yes, sir. Yes.
Sir, we have already taken that question about clinical diagnosis of, threatened miscarriage, which you have answered before with natural micronized progesterone, where Sacconi and Hess has already taken, done trials, and Cochrane. So can we move to the next question, sir?
Yes, yes.
I want your insight on, can we combine low dose aspirin or LMWH with oral micronized progesterone in patients with recurrent early pregnancy loss? And does it result in improved live birth rate and low miscarriages? In your practice, what have you to say, sir?
Dr. Niranjan, one by one, very nicely you have taken all the questions coming from the audience, because these are the usual questions which audience wants to know, and these are the usual question marks in their thinking. So we have to help them out with whatever we know regards this topic. A small trial showed comparable results with low molecular weight heparin plus aspirin as an alternate to unfractionated heparin and aspirin in the management of recurrent miscarriage secondary to APS. Now, as we all know, previously unfractionated heparin and unfractionated heparin with aspirin was much used. But nowadays, these new trials are putting in low molecular weight heparin plus aspirin and showing very superior results. A combination treatment consisting of high dose, low duration prednisolone, progesterone, and aspirin also showing very good effective treatment. So actually, two groups of workers going parallel at present in showing us results, one with low molecular weight heparin and aspirin, another with prednisolone, progesterone and aspirin. Women with a history of idiopathic recurrent miscarriage were treated with prednisolone 20 milligram per day, progesterone 20 milligram per day for the first 12 weeks of gestation, aspirin 100 milligram per day for 38 weeks of gestation, and folate 5 milligram every second day throughout their pregnancies. 50 of the 80 women became pregnant. They were compared with 52 women with idiopathic recurrent miscarriage, matched for age and number of miscarriages, who became pregnant without treatment during the same observation period. And what were the results, which would be very interesting for all to know? The overall live birth rate of the treatment and control groups were 77% and 35%. See, such a vast difference in the treatment group and control group. So very well we can know that the treatment group has given very good results. The rates of first trimester, median gestational age at birth and median birth weight did not differ between the groups. Conclusion, a combination treatment of prednisolone, aspirin, folate and progesterone in association with a higher live birth rate compared with no treatment at all in women with recurrent, idiopathic recurrent miscarriage, but this showing the same results as low molecular weight heparin plus aspirin also. Thank you.
You have to unmute yourself.
Yeah. Thank you so much. Wonderful presentation, wonderful question answer session, which has been going, and we're very happy. And I think it's already dinner time. So,
I think we have covered all the questions which have come from the audience. Most of the questions we have covered up.
So while I end with a few thoughts which are personal, Namaskar Dosto, I want to dwell on them. My thoughts, some which I came across. Communication again. Have we ever thought we are like remote controlled devices? We receive verbal, visual commands, process them in context, and take what we think is right. Am I right? Yes. But while doing this, we invest, we invoke. We have got multiple chemical reactions inside our bodies. Some of it we store inside us and continue to refer to it. This plays a very critical role in our behavior, in our actions, and how we progress in life. It is not easy to give ourselves time to pause, relate in context, evaluate choices, and take appropriate actions. We are exposed to many such potentially important situations daily in our personal, in our professional, and social life. So it's wishing you all that it's always, you have to find time, a right attitude, see holistically, view, and courage to choose what is right and make things better than before. So I thank all of you with a wonderful viewership which we have got today, and Dr. Jayesh, Dr. Percy sir, Yogini madam, and Mona Shroff madam, you have given an excellent view on recurrent pregnancy loss. So with this we end. Thank you so much.
Thank you.
Thank you very much, sir, for the lovely moderation. Thank you very much, all the participants.
Yes.
Thank you.
Thank you for the dokla.
Good night.
Thank you so much, doctors. Thanks for your time.
Bye.
Appreciate the discussion. Thank you so much. Thanks, Dr. Niranjan. Thank you, sirs. Madam.
Bye.
Thank you, sir. Thank you. Bye.
Bye. Good night.
Wonderful.
Thank you, mobile માં મારા ઉલટા સુલટા ક્વેશ્ચન પણ કે પેલું કેમ જતું રહ્યું
ચાર્જિંગ પૂરું થઈ ગયું હવે ચાર્જ કરી નાખ
બોલ મારો ક્વેશ્ચન આવ્યો ને ત્યારે જ પૂરું થઈ ગયું
એટલે કોઈ બટન નહીં દબાઈ
નહીં મેં તો કઈ નહીં, મેં તો આમ જ કરેલું. તો તે ખાધું નહીં? મારા ટાઈમ ક્વેશ્ચન ટાઈમ પર જ આવી ગયું. મારા ક્વેશ્ચન ના ટાઈમે જ ગયું. નહીં પણ લગાવું ને એટલે પછી બીજો ક્વેશ્ચન તો મને એટલીસ્ટ ખબર પડવું છે ને. પેલું પાછું અવાજ નહીં આવતું તો આપણે જે બોલીએ તે લોકોને નહીં ખબર. એ લોકોને મને નહીં સંભળાતું તો મેં હેલો એટલે પછી મેં આમાં કર્યું.